Hello, everybody, and good afternoon. My name is Catherine. I'm a white woman with dark hair, a white shirt, and a beige sweater, and I work on the communications with the National Center for Medical Legal Partnership. On behalf of NCMLP and our wonderful partners at Health Outreach Partners, I'd like to welcome you all to the third webinar of our series, The Unique Role of Medical Legal Partnerships in Helping Health Centers Address Disability and Chronic Disease Discrimination. Before we get started, even before housekeeping and all that, I want to take a very brief moment to recognize each and every one of you. Part of my job is to find the right thing to say or the right words, and there really are none. So the best that I can offer, and it's certainly not enough, but the best that I can offer at this time is a very sincere thank you for continuing to put in the work to make this world a better place and to continually take care of people. It can be really difficult, especially at times like this, but we see you and sincerely hope that you're able to take some time to take care of yourselves and your families this week, to breathe and to love one another. But we're here today with an excellent panel of experts who are going to work with us through this issue of COVID and long COVID. So this project is funded by the Health Resources and Services Administration of the Department of Health and Human Services, but any content or views expressed herein are not necessarily indicative of the opinions or an endorsement by HRSA, HHS, or the US government. Next slide, please. You have all joined this webinar on mute and will remain muted for the duration of the event. However, we encourage you to ask questions via the Q&A function in Zoom or comment in the chat. We're joined by our two wonderful ASL interpreters. If you need their services and are unable to see them, please ensure that your view is set to side-by-side gallery by using the view settings, typically in the upper right-hand corner of your screen. We're also utilizing Zoom's live transcription function. If you need to see these captions, please use the live transcript button at the bottom and hit show subtitle. This webinar is being recorded and a copy of the recording and slides will be available on our website in the coming weeks. And finally, if you need any assistance at all, please feel free to email ncmlp@gwu.edu for help. And with that, I am very happy to yield the floor to Katie Hathaway to kick us off. Katie, it's all you.
Thank you, Catherine. Appreciate that. As Catherine said, I'm Katie Hathaway, your moderator for today's webinar. I am a white woman in my mid-40s with long, straight brown hair, brown eyes, and I'm wearing a blue and white gingham jacket and a white shirt. And my pronouns are she and hers. I'm working in this capacity as a consultant for the National Center on Medical Legal Partnerships, leading this series. I have nearly 20 years of experience as a disability rights attorney, and for 17 of those years, I helped build and then led the American Diabetes Association's legal advocacy program, who sought to end discrimination against people with diabetes. So I'm going to introduce you on the next slides to each of our speakers who are experts in their field, and I hope you will enjoy hearing from them today. The first one that I have up here in alphabetical order is Claudia Center. Claudia is the legal director for the Disability Rights, Education, and Defense Fund, where she litigates cases that increase civil rights and civil liberties for persons with disabilities. And she represents the disability community in legislative, policy, amicus, and appellate work. She's previously worked at the ACLU, Legal Aid at Work, and NARAL Pro-Choice America. Christian Ramers is a physician who pursued an undergraduate degree in microbiology and molecular genetics at UCLA, medical school at UC San Diego, and residency training in internal medicine and pediatrics at Duke University Medical Center. He completed his fellowship training in infectious diseases and earned a master's degree in global public health at the University of Washington in Seattle. He currently serves as the Chief of Population Health and Director of Graduate Medical Education at the Family Health Centers of San Diego, a large federally qualified health center system serving nearly 200,000 medically underserved individuals throughout San Diego County. He is board certified in internal medicine, infectious diseases, and addiction medicine, and is particularly interested in HIV, HBV, HCV, and service of medically underserved immigrant and refugee populations. He is a core member of FHCSD's COVID-19 response team, delivering bi-weekly updates to more than 200 clinicians and staff. He is the principal investigator of an NIH-sponsored research trial on prevention of household COVID-19 transmission. And he serves on the NIH Long COVID Review Panel and leads, oops, I'm sorry. Screen just moved around. And leads a group CDC grant on long COVID. Sorry about that, Dr. Reimers. And our third speaker is Rachel Weisberg, who is an experienced disability rights attorney who has represented hundreds of clients in individual and systemic disability discrimination cases. Rachel is the managing attorney at Equip for Equality, where she developed and now manages its employment rights helpline, which aims to expand employment opportunities by providing legal and practical advice to applicants and individuals with disabilities. Rachel is a frequent trainer on the disability rights laws and speaks regularly at national conferences and webinars. Prior to Equip for Equality, Rachel worked for the Illinois Attorney General's Office, Sidley Austin LLP, and clerked in the Northern District of Ohio. Rachel is a graduate of Northwestern University School of Law and the University of Michigan. So before we jump into what today's presentation is going to cover, I did want to sort of piggyback on what Catherine said at the beginning of this session, which is I want to acknowledge that in the only 2 weeks since we last had one of these webinar sessions, we've had 2 mass shootings in this country. And all of the pain that we're feeling because of that. And you may have intended to participate in today's webinar and now find yourself unable to concentrate, which is okay. I understand that. Can't say I'm not there myself. And so if you need to step away or take time away or even pick this up later, just know that today's webinar, as noted, is being recorded. And both the video of this session and the slides from the session will be posted on the National Center's website where you can view it later if that's easier for you. So with that said, a few things that we're going to cover today. This session is focused on COVID-19 and sort of the emerging issues that have arisen because of the COVID-19 pandemic. So we're going to talk a bit about COVID-19 and long COVID as disabilities, sort of the newest disabilities on the scene. We'll talk about some of the emerging issues that we're seeing from the health center perspective, from a disability rights perspective. And then we're just going to jump into a panel discussion. Myself and the other 3 speakers are going to talk a bit about what does it look like to navigate the workplace during COVID and when you have COVID or have long COVID. And then at the end, we will have sort of an open question and answer period. So as noted, I hope you will put any questions that pop up into your mind as we're talking, put them in the question and answer box. So that we can either address them as we go or address them at the end of the panel discussion. So let's start with long COVID, a bit of what it is. And I think something you may hear us all say frequently throughout this session is that there is probably a lot more that we don't know than we do know about long COVID. But to give us a little bit of a framework for what we're talking about here, there are no, at least to my knowledge, Dr. Reimers will correct me if I get this wrong, but there are no diagnostic tests to diagnose long COVID. And I think more often than not, it ends up being a diagnosis of exclusion, perhaps testing and then ruling out other potential causes of symptoms. There are several different definitions that I've seen for long COVID. A few of them here on the screen are different categories of people who may be experiencing quote unquote long COVID. Some of them may have direct cell damage caused by a COVID-19 infection that takes time to recover from. Examples are probably acute kidney damage, acute lung damage. There are also people who are hospitalized with a COVID-19 infection who experience long-term complications from being in the hospital for a long period of time. For example, muscle weakness, neurological damage, lung damage. A third category are those people who have new or recurring symptoms that originate or last beyond the initial COVID-19 infection. You've probably heard about this in the news a lot more frequently than those first two categories of people. The symptoms really vary person to person. Some of the most common that have been reported by patients are fatigue and brain fog, headaches, shortness of breath, loss of taste or smell, all of various levels of severity. And the CDC itself, the Centers for Disease Control, defines long COVID as existing when an individual experiences new, returning, or ongoing health problems 4 or more weeks after the after initially being infected with the virus that causes COVID-19. The very last bullet here, I think, is an important one to give some context to these discussions, because it's all about how many people are being impacted by this. And again, Dr. Ramers will have a lot more direct experience and knowledge of this, but some of the estimates that have been being published recently say anywhere between 10 to 30% of people who are infected with COVID-19 end up experiencing some form of long COVID. That's a lot of people. So as much as we don't know about long COVID, there are a lot of people who are suffering with it. And so even on the low end of that estimate, that's millions of people. So I think it's important to know how to think about long COVID in the framework of disability, so that we're all prepared to help our patients and our clients navigate, get the legal protections and then navigate living with and managing those conditions. In the very first webinar in this series, we talked about what constitutes a disability, what is the definition of disability. And the primary definition that we have been working with is the one that's found in anti-discrimination law, including the Americans with Disabilities Act. I will just note that one of the other definitions that we briefly touched on in that first session was that of Social Security disability decisions. And I will say that I think that that is likely to become a focus of attention if people with long COVID are regularly having claims denied in that system. So that is something to watch, but our focus again for this series is on federal anti-discrimination law. So on that point, I'm going to turn it over to Claudia, who will talk a bit about how we analyze disability under these laws, and then we'll come back and talk more about COVID and long COVID and where the law is.
Sure, this is Claudia, and I'm going to talk a little bit about the definition of disabilities under the ADA. And if you are a relative newcomer to the world of disability rights, it's very important to understand that the rules that apply now to federal disability rights claims are set by the ADA Amendments Act of 2008. So you definitely do not want to rely on pre-2008 case law that construes the definition of disability narrowly. So what we have under the ADA Amendments Act is we have the same definition of disability that we've had all along since 1974 in federal law. So you have to show a physical or mental impairment that substantially limits a major life activity, or a record of having such an impairment, or being regarded as having such an impairment. And I'll talk a little bit more about the regarded as prong. So what is really important is that the ADA Amendments Act expanded the list of major life activities that have been kind of blessed by Congress, and added this concept of major bodily functions to major life activities. And the reason this is important is prior to this statute, many pretty significant from advocates' point of view disabilities were found by courts not to be covered disabilities. So now our major life activities include a number of conditions that are potentially relevant to COVID or long COVID. So I won't read the entire list of major life activities in the statute, but some of them include sleeping, walking, speaking, breathing, learning, reading, concentrating, thinking, communicating, and working. And so those, some of those major life activities may be relevant to COVID and long COVID, things like communicating or thinking or reading or concentrating. And the same with major bodily functions. There are a number that are very relevant to COVID and long COVID. I won't read them all, but some of them are the functions of the immune system, of normal cell growth, neurological function, brain function, respiratory, circulatory. And then when you go into the regulations, you get cardiovascular, circulatory and hemic, and lymphatic. So a lot of conditions and body systems are specifically mentioned by Congress and are sort of blessed by Congress and by the EEOC and DOJ and their regulations. The other thing that's important is that the ADA Amendments Act says that you are covered if you are substantially limited in one of these major life activities, even if your condition is episodic or goes in and out of remission. And that's really important for long COVID because it is, for many people, episodic, or people will have good days and bad days. And what the ADA Amendments Act says is if you're substantially limited at times when your condition is active, then that means you're covered. The ADA Amendments Act also says that you do not consider the positive effects of mitigating measures in whether someone has a disability. So if someone is having a treatment for long COVID that is helping them function better, you don't consider the positive effects of that treatment. So the reason this is important is that people who are quote unquote disabled under the ADA have access to non-discrimination and reasonable accommodations. And we'll talk more about those. If you are regarded as having a disability only, and you don't actually have a substantial limitation, either currently or in the past, you do not get an accommodation under the ADA Amendments Act. You only get non-discrimination, but that's still important. So that's a high-level overview of who's disabled under the ADA, and 504, the Rehabilitation Act, tracks the same definition. And that's the story. There's a lot of room to be creative and to make good arguments under this amended definition.
Thank you, Claudia. That's a great like you said, high level overview, but a very important tool for navigating this space. So I'm going to turn it over to Rachel and ask her to talk a bit about COVID-19 as a disability, where things stand.
Thanks so much, Katie, and hi everyone. I'm Rachel Weisberg. As Katie mentioned, I'm a attorney at Equip for Equality, and I'm a white woman with red hair. I'm in my early 40s, and I'm wearing glasses today. I don't always wear them, but I'm wearing them today. And I'm happy to be here to talk a little bit about how are we applying these traditional ADA principles that Claudia went over so nicely to the context of COVID-19. This is something that we as advocates have been thinking about for 2 years. And so we, at the beginning of all of this, started coming up with how we think it would be analyzed. And then over the last 2 years, we've gotten a little bit more information, first from the EEOC and the Department of Justice. And more recently, we're starting to see some court cases analyzing COVID-19 as a disability under the ADA. So hoping to share all of those different perspectives with you all. So to start with, of course, as Claudia mentioned, to have a disability under these anti-discrimination laws like the ADA, somebody to fall under this actual disability prong needs to have a physical or mental impairment that substantially limits a major life activity. Okay, well, there's lots of different groups that could apply to when we're looking at COVID-19. So the first is the bucket of people who have a pre-existing impairment or disability, and that impairment or disability puts them at higher risk of severe complications or death if they contract COVID-19. And so those are people that the CDC has designated as folks who have a higher risk. So, for example, people with asthma or people with different types of other underlying impairments. And so for those individuals, I think it's been pretty clear all along that those individuals are going to be people with disabilities under the ADA because they have this pre-existing impairment that substantially limits a major life activity and their increased risk of severe complications as a result of COVID. So that's bucket number one, the first bullet point. It's important, though, to remember that when you look at those CDC risk factors to determine who is at greater risk of severe complications, not everyone who falls within a CDC risk factor is necessarily going to be a person who's covered for these anti-discrimination protections. And the reason why is that there are some risk factors that the CDC outlines that are not underlying impairments as defined by the ADA. So, for example, age. We all know that folks who are that are older, there's some additional likelihood of severe complications from COVID. However, age in and of itself is not an impairment. It's not a qualifying impairment under the ADA. So if somebody is older and they are looking for some ADA protections, we'd want to look at whether they have kind of something else, an actual underlying impairment, maybe a heart condition or someone who's hard of hearing or something else that's going to be associated with the age that would provide them with ADA protections. Similar concept to pregnancy. Pregnancy, I believe, is on the list of folks who may have severe complications. However, pregnancy under the ADA is not in and of itself a disability because pregnancy is not an underlying impairment. Certainly, there are pregnancy-related impairments that get you that type of coverage. So someone who maybe has pregnancy-related diabetes, gestational diabetes, pregnancy-related sciatica, there are ways to show if somebody has a condition that's related to pregnancy that they might have an underlying impairment, but pregnancy itself isn't going to get folks there. So again, it's important to kind of look at it more broadly. Is there something else going on other than the underlying pregnancy? And then finally, obesity is referenced as a condition that puts someone at a higher risk. And there's somewhat of a split in the courts, but the majority of courts who have looked at this issue have said that obesity, again, in and of itself is not an underlying impairment under the ADA. So therefore, if somebody has a severe risk because of obesity, we'd want to look at whether there's any other factors, hypertension, diabetes, something that's associated with obesity that we would want to point to give them qualifying protections. Okay, so then there's the question, right, of whether or not COVID-19 itself, even if is a disability. And that's something that, again, we've all been thinking, how do we get there? And so, the question is, can we go through that analysis that Claudia laid out to show that somebody who has contracted COVID-19 has a disability? And so walking through that analysis again, starting with number one, does somebody have an underlying impairment? And what I think is now clear, which wasn't necessarily clear at the beginning of all of this, is that the EEOC, the Department of Justice, and courts are saying, yes, COVID-19 is an impairment. Therefore, you've got the first bullet point checked off. You have an underlying impairment. But it gets a little bit more nuanced and complicated from there, because then the next question is, okay, does that impairment substantially limit a major life activity? And I think the answer to that is the thing that we always say as lawyers is it depends, right? Everything under the ADA really requires this type of individualized look at the individual. And so in some situations, somebody who has COVID-19, as Claudia explained, is going to have some substantial limitations in major life activities like breathing or concentrating or interacting with others. But then there's going to be some people who have had COVID-19 that either were asymptomatic or their symptoms were really, very minor. They're probably not going to rise to the level of COVID-19. And so it's going to really require some sort of individualized look. And that is consistent with what we're seeing in the courts. So long as folks are saying in the courts, look, I have COVID-19, as a result, I have this substantial limitation, then they're getting to the point where they're able to make a case, but they has to do more than just say, I'm somebody who has COVID-19. And then it's really important to remember that even if someone's initial case of COVID-19 doesn't rise to the level of an ADA disability, perhaps it could cause an impairment that itself is a disability, something like heart inflammation, stroke, or diabetes, or potentially worsen a pre-existing condition that previously wasn't substantially limiting. So that's an overview, and we can definitely talk more about how this is played out in the courts in our later discussion.
Thank you, Rachel. Very important information. And as you said, on our minds for the past couple of years. So talking a bit about long COVID as a disability and what is the state of the law here. I think this is an area where, because by its very nature, it hasn't been as present or as front and center as the actual COVID-19 infection has been, or at least hasn't gotten through the courts at such a volume as we might expect in the coming months and years. It's a place where we rely a little bit more on guidance from the federal government. So the federal government, through the U.S. Department of Justice and the U.S. Department of Health and Human Services, last summer issued guidance on long COVID as a disability under 3 laws: under the Americans with Disabilities Act, as we've been discussing, under Section 504 of the Rehabilitation Act, and under Section 1557, which is the non-discrimination provision of the Affordable Care Act. And what that guidance says in a couple parts is that long COVID is a physiological condition that affects one or more body systems. So it constitutes a physical or mental impairment, that sort of first prong that Claudia and Rachel were talking about. And that in some cases it can substantially limit a major life activity. But just like all of these other points, whether it be COVID itself, whether it be pre-COVID, evaluating whether an impairment is substantially limiting, it's a very individualized assessment. It's not an automatic disability, but it is important that the federal government issued this guidance and said that this can be a disability. In fact, in that guidance, they provide a few examples of when long COVID would be a disability. One of them that they provided is a person with long COVID who has lung damage that causes shortness of breath and fatigue. And that person, they said, would probably be substantially limited in respiratory function, among other major life activities. Another example that they provided is somebody with long COVID who has symptoms of intestinal pain, vomiting, and nausea that have lingered for months. And that person is probably substantially limited in gastrointestinal function, amongst perhaps other major life activities. And a final example that they provided is somebody with long COVID who experiences memory lapses and brain fog is probably substantially limited in brain function, concentrating, and or thinking, or perhaps other major life activities. In addition, on the employment side, the U.S. Equal Employment Opportunity Commission, otherwise known as the EEOC, issued similar guidance about COVID-19, which touches on long COVID, provided also similar examples of when long COVID could be a disability. There aren't as many court cases out there yet on this, but as I said, I think we're going to start seeing them in a couple of different areas. So that is long COVID. Before we move on to the next section, though, one thing I think is important to keep in mind, and especially the longer that the pandemic continues, it's important to know that, and this is something that the government, the Department of Justice, has stated and made clear, that the civil rights protections that were in place prior to COVID remain in place during COVID and during this pandemic. There are a lot of things that had been waived during the public health emergency, but the applicability of civil rights laws, federal anti-discrimination laws, is not one of them. So I don't know whether that will come up in practice very often, but there's a lot of things that have changed over the course of the pandemic, or been enabled or disabled, no pun intended, because of the public health emergency. But civil rights protections remain in place. So with that, I'm going to turn it over to Dr. Rammers and ask him to give us his thoughts, see what issues you're seeing in practice related to COVID and long COVID.
Thank you so much, Katie, and it's really good to be with you and with Rachel and Claudia. I'm learning a lot myself in an area where I think we are very much in uncharted territory. My name is Christian Rammers. I'm a Hispanic white male, short hair and wearing a blue shirt and a red, gold, and blue tie. I am an infectious disease physician and serve as a chief of population health at Family Health Centers of San Diego, as Katie mentioned, which is a large federally qualified health center system composed of 23 clinics, mainly treating underserved and lower socioeconomic status individuals in San Diego County. We have had a very outsized role in the COVID pandemic, providing testing, telemedicine, and management of COVID cases. I just looked it up, and I'm surprised to say we've actually diagnosed 20,000 people with COVID in the county. When they became available, we provided mass vaccination sites at many of our clinics. Since December of 2020, we've been able to provide treatments, since they've been available, in the form of monoclonal antibody infusions. And then in the aftermath, even though the pandemic is still occurring, we are now getting involved in treating long COVID patients. And we're involved in a educational effort supported by CDC to try to at least start the discussion and share best practices on how to manage long COVID in the primary care setting. So that's the perspective I bring. I'm just going to speak for a couple of minutes on what things look like from our perspective. So first of all, Katie mentioned that we think about 10 to 30% of people with COVID will have some form of lasting symptoms. And although we don't have a very tight definition of what that means and what long COVID even means, it can be any system throughout the body, whether it's the nervous system, the brain, the cardiovascular system, or the heart, the lungs, the pulmonary system, or frankly, anything, whether it be immunologic, the gastrointestinal system, anything that lasts beyond 1 month from the original COVID infection is considered long COVID. I mentioned we don't have a very tight definition, and that's because this can look like anything. We're seeing a huge diversity of presentations of this illness. And we, as a medical community, have not even really agreed on a specific definition. You will actually hear several terms. Long COVID is one of them, but there is another one, which is PASC, or PASC, which stands for post-acute sequela of COVID-19. And the CDC has been moving towards a broader term, which is post-COVID conditions, or PCC. Other countries have defined this actually as only those symptoms beyond 12 weeks, and that seems to be the WHO's definition. So just from the start, we're already all over the place in terms of defining this problem. In terms of the scope of the problem, if you think of how many people have had COVID, have contracted COVID, and you take 10 to 30% of those, this is an enormous number of people. There is a dashboard that has been put together by a group of physicians from the American Academy of Physical Medicine and Rehabilitation, AAPM&R, where you can actually plug in your own jurisdiction and use a slider to say, is it 10%, 20%, 30%? And it gives you at least some idea of how large a problem this actually is. For example, I plugged in San Diego County's numbers, and there are probably 100,000 people in San Diego who qualify by the definition of long COVID. The US Government and Accountability Office recently has a publication on their website estimating 7.7 to 23 million Americans currently with long COVID. So a huge problem. And one additional publication recently that was put out by the Fair Health organization, which is a nonprofit that looks at healthcare costs and insurance issues, also gave us some additional information about what these patients look like based on a sample of 78,000 individuals who had the ICD-10 code of post-COVID condition on their charts. And what is remarkable about these patients is that 75% of them actually had mild to moderate COVID to begin with. These were not patients in the ICU. These were not patients who were even hospitalized, and yet they had been assigned the diagnosis of long COVID. Many of these patients, about a third of them, were in younger age groups in their 30s and 40s. Even children as young as less than 12 years of age were included in this sample. And the typical complaints that went along with the diagnosis were breathing abnormalities, shortness of breath, fatigue and malaise, and brain fog, all of which are things that are not necessarily easy to just send a test and have a diagnosis. And I'll make one additional point, which is that sometimes we do a whole battery of testing and it all comes out normal, and yet the patient in front of us can still barely get out of bed or can barely think through their day in the way that they normally would before having COVID. So in terms of generating evidence that we as physicians can point to and say, this is an abnormal X-ray, or this is an abnormal test, many patients that are suffering profoundly disabling symptoms, the testing actually comes out normal. And I think that speaks to the idea that this is such a new condition that we have not even really defined it yet, and nor do we have the right diagnostic tools. And the last thing I'll say before turning it back to Katie is, what does this look like as a health center? It is frankly chaos for us. We have patients that are trying to get back to work, who are being asked or told by their bosses to get back to work, and yet they have these ongoing, profoundly disabling symptoms. And in our patient population of those that are from minorities and from lower socioeconomic status, they really just don't have the self-efficacy to ask for help or to know what to do. So I look forward to discussing more in the question and answer section.
Thank you, Dr. Ramers. I'm going to pose this to Claudia or Rachel and see if there are any sort of open comments, any trends or issues that you're seeing from the disability rights legal practice perspective over the past couple of years. Anything we should keep our eye on?
Well, this is Claudia. This is going to be news to no one, but I think that we have, as advocates and lawyers, we have lots of evidence that COVID and long COVID and conditions associated with adverse outcomes from COVID are disabilities, in addition to all of the impacts on major life activities that we've been speaking of already. We have the way that COVID attacks cells in the body, even if it's an asymptomatic or less symptomatic case. We know that it attacks cells in the body. It hijacks human cells in a way that affects normal cell growth, which is a major life activity under the ADA as amended. We know that we can argue that we consider the person as though they have received no treatments at all. For example, we can assess what the person would have been like had they not gotten the monoclonal antibody infusions and so on. So we have a lot of tools on paper, but what I think the reality is that we're going to be facing employers that are increasingly impatient, that are viewing their employees as malingering, are expressing skepticism about disabilities because, as Dr. Raymer said, we don't yet have a piece of paper, a diagnostic test that is positive for long COVID, even if somebody can hardly get out of bed. And so that's the situation we're facing. There is a history of this in disability rights world, where people with conditions such as Lyme disease or chronic fatigue or fibromyalgia and other conditions that were faced with skepticism have had to fight to access accommodations at work. And so we're going to be building on that, but with on a much greater scope, greater population.
And I agree with everything Claudia said. And just one quick follow-up, and then I'll make another point. But I think just given how many more people are going to be identifying as disabled and needing to explore the accommodation process, I think it's so important to get, I spend a lot of my time counseling people on how to ask for accommodations. And even though the ADA has been in effect for 32 years, there's so much that I think both employees and employers don't know about the complexity of the process. And so the more that we as advocates can be out there guiding people, empowering people about what their rights are and how to more effectively advocate for it, I think, all the better. The one other, I guess, emerging issue, and I think this goes in Claudia's view of things that probably won't surprise anyone, but, for years, people with all sorts of different disabilities have asked to work remotely as an accommodation. And for years, we've heard employers say, like, we can't do it. That's impossible. That's infeasible. And then for years, these cases have gone up to the courts and judges have kind of scratched their head, and sometimes courts have said, okay, but generally speaking, there's been a lot of skepticism about work from home as an accommodation. And so I think when the whole world transitioned to remote work for, many different industries, there was this kind of like, we told you so moment for the disability community of like, we could make this work. And we've been waiting to see how this is going to play out. And I think in some ways, there's going to be some really, really positive changes. And again, we're starting to see some cases suggesting that the fact that someone was working remotely during the pandemic is great evidence and an indication that they can work remotely for other disability related reasons in the future. But I'm also a little fearful that we're starting to see some pullback from employers that, okay, that was like a fun experiment while it lasted, but now, oh, by the way, it's so critical, even though, yes, you did it. And yes, you may still need to for other disability related reasons, we're going to scale back. And so I think it's an issue that needs to be kind of front of mind for all of us of how do we continue to say, yes, this has been a really, really hard couple of years. So let's try to learn the pieces that we've learned to expand rights and kind of push that piece forward.
Thank you, Rachel. This touches on a lot of the issues that we're going to sort of dive into now and have a bit of a more discussion. And I think I want to start by talking about accommodations generally, and we can go into some of the remote work accommodations, but picking up on the thread that you and Claudia discussed, what would you say, and I guess I'll direct this to Rachel just for continuity here, what would you say is the status of workplace accommodations related to COVID or long COVID now, and do they look different than they did earlier in the pandemic, or does the phase of the pandemic change the nature of the accommodations sought or needed?
I think every day it's different, right? I mean, sometimes and I think this is the nature of disability, right? Like everyone's needs are different. things differ based on context. And so just kind of like one thing that pops to mind is, the evolution of masking. And, I think we have some folks who have asked for more masking in a workplace as an accommodation. And I think whether or not that's been that's been something that's been received well by an employer has changed as kind of the public guidance out there on masking requirements has changed. I also think given the difference in the variants, there's been a little bit of a difference of how things are being received. So I think, and I feel kind of odd saying this in front of a doctor who knows way more than me, but what I've seen is, not once people were vaccinated and then the relative different kind of severity of a lot of folks who acquired the Omicron variant, I think we are seeing some pushback from employers like, okay, we let you work from home, or we let you have this other accommodation when there weren't vaccines, and when, the variant was really, really dangerous. But now everyone's, people are vaccinated and Omicron's not that bad, so come on in. And I think that's wrong, but I think there has been a little bit of a shift given the different variants that are out there.
Dr. Ramers, I'm curious, would you agree with that sort of perspective, or does it align with what maybe your patients are experiencing or sharing with you?
Well, just to follow on Rachel's point, it's really confusing what's going on, because the newest variants, the BA 2.12.1 actually looks like it's probably just as severe as Delta. And so what really is changed and has changed is the context. And yes, vaccines have really helped keep people alive and out of the hospital. But it sort of blows my mind that that long COVID has been left out of a lot of that conversation. And even, I respect Tony Fauci a lot. He's been an infectious disease leader for 30 years, not just the last couple of years. But I saw an interview with him and he didn't even mention long COVID. And it was just not even on the radar screen. So what we're seeing is an outcome that is much harder to put your finger on. It happens in a much more delayed manner. And it's really, frankly, not part of the central conversation of what we should be even thinking about with COVID. Vaccination certainly does reduce the risk of long COVID. The summary estimate is about by half, maybe protecting people from developing long COVID, but there are still plenty of people who are vaccinated who have mild cases and still do develop long COVID. So in that way, this is going to be with us for a long time, no matter what the variants are, and no matter what the vaccination rates are, and no matter what the context is. Again, all of this discussion just sort of smacks of us not really knowing what's going on and really having to work it out little by little. The last thing I'll say is that the numbers can be really, really overwhelming when you look at so many millions of people that have long COVID. But what we're seeing clinically is really a subgroup of those that technically qualify as having long COVID as being the most profoundly disabled. And it may be that this is something we've seen many times before. In fact, it has a name. It's called myalgic encephalomyelitis and chronic fatigue syndrome. And there's been really an interesting kind of concurrence of the advocacy community and CDC getting together to say, boy, this actually looks a lot like chronic fatigue in the past, which has, been a difficult slog for that community to gain recognition and disability rights and what have you. But I think it's sort of a convergence of those two things, saying this is real. The NIH is going to put $1 billion towards researching this, calling under the name of long COVID, but we may make breakthroughs in really finding out what chronic fatigue actually looks like. And that is going, in my opinion, is going to be a smaller percentage than 10 to 30% of everybody who developed COVID. It may be 1 to 5%, but that is still a whole lot of people.
Yeah, it's a frightening number of people whose lives have changed quite a bit. And it's a huge impact on the workplace, on a lot of different systems. Thank you for that. I'm curious, Claudia, I wanted to pick up on something that you mentioned earlier about sort of getting around employer skepticism and sort of the malingering and how attitudes have changed. I'm wondering, is there anything practical that you can think of that a patient who is now living with long COVID could learn from, and picking up on Dr. Raymer's thread about chronic fatigue, what can some of these individuals learn about navigating the workplace and the accommodations living with a chronic disease now from those other communities that have this long experience, as you both said, sort of long and frustrating. But are there any lessons that we can learn from that, either on the employer side or the employee side navigating that?
Well, this is Claudia. I think that part of it is really going back to basics, going back to what is the accommodation process. And Rachel and I and others are able to connect people who are in this webinar with disability rights experts in your region. Most likely, there may be some regions where we can't. And those advocates can help make sure that you give the most complete and up-to-date advice to patients and clients. But the main thing is for the individual employee to keep communicating with the employer and keep considering how they can participate and do their job with reasonable accommodations. And so, the reasonable accommodations that are going to be relevant include leaves, and this is for all disabilities, but back to basics. This is how it will work with long COVID as well. So it's going to be leaves of absence. It's going to be changes to your work schedule. We're going to probably see a push for part-time schedules. And the courts have been mixed on that, but I think that the better view is that a part-time schedule can be a reasonable modification. There may be requests for job restructuring to take out certain pieces of a job that may be harder for the person with long COVID to do. Maybe the traveling piece, if traveling is particularly exhausting. That again, the courts have been mixed, and we're going to need to be prepared to fight and to advocate for those kinds of, I call it robust job restructuring. Transfers to vacant positions can be relevant. And then for COVID in particular, we are also talking about sort of safety in the workplace. So we're talking about air filters and masking and social distancing and considerations around groups. Are you going to have any group meetings? And if so, where are they going to be? Will they be inside? Will they be outside? And of course, telecommuting. And I also wanted to mention in our own workplace, and this just shows the point about multiple disabilities. We have people who do not travel to our workplace because they are highly, highly immunocompromised due to pre-existing disabilities. Since we're a disability rights organization, we have many different disabilities represented on our staff. We have another disabled employee who, because of her severe migraines and inner ear related disabilities, cannot participate in Zoom. Zoom gives her migraines. And when she meets with people in person, she needs them not to wear a mask because she's hearing impaired from her disability, or to wear a clear mask, but even the clear masks are difficult. So it's become, exercise and creativity about meeting outside in our terrace and with social distance and so on. But yeah, going back to basics, what's the job, communicate, and think about how you can still participate in the workplace and, make the employer say no, keep being creative and offering ideas for how to make it work.
I like that last line, make them say no. That's a really good motto to live by. So I'm curious, Rachel, I'm curious what you think, whether the pandemic itself has changed anything about the kind of medical documentation that you might need to provide to an employer to support a request for a reasonable accommodation. And then Dr. Reimers, I'd love to get your thoughts on that as well.
I'm curious if anyone disagrees, but I don't think so. I mean, I think a lot of COVID-19 has been, let's take these traditional principles that we all kind of know and have applied for years, and then let's just take this kind of new layer and add it on. And so, the rules have been quite clear that employers, can ask for reasonable medical documentation to support an accommodation need if only and if the accommodation isn't obvious, the disability isn't obvious, and then of course the documentation needs to be really narrowly tailored to identifying that the person has a disability and that they need this particular accommodation. And I think that principle still applies when somebody is asking for accommodations related to COVID or long COVID. So I think it's the same.
Okay. What does it look like in practice if you have some experience, Dr. Emerson? I'm curious. There's sort of on paper and then there's in practice, and I'm curious, especially for long COVID, for which we don't have a lot of information yet, what that looks like.
Right. Well, I would start by saying that we're doing our best to educate primary care clinicians that this is real, because there are still many clinicians, and we hear about this from our patient advocacy groups all the time, who don't necessarily quote unquote believe in this, and they actually think this is a psychiatric disease and that people just need to motivate and get out of bed. And it's created this awful tension of gaslighting many of these patients who can't get a physician to document that they actually have symptoms, mostly because these are symptoms and this is a disease that relies upon patient report. And in many cases, the medical documentation that we are used to seeing, which is a stress test or an X-ray, they come out normal. And so the documentation that we are having to submit is really a physician report of patient symptoms. So the first task, I think, is getting physicians to believe their patients and believe that this is real, and then work on things that they may not be comfortable with. For example, one of our faculty named Cindy Bateman, who's been treating chronic fatigue for decades, uses something called an hours of upright activity index, where she just asks patients how many hours in a given day are they able to be standing up. And in people with the most severe form of chronic fatigue, of MECFS or of long COVID, that's on the order of 0 to 3 hours. And this is not a validated medical test or anything, but it is the kind of documentation that we are stuck with. I also mentioned in the chat a little bit that other conditions that, again, we just don't have a great understanding of, such as cardiac manifestations or POTS, which is postural orthostatic tachycardia syndrome, are indicative of profound damage to the body, and in particular, the autonomic nervous system of the body, that I don't have a great test at all to be able to send. And it's quite sophisticated and takes a really tuned in clinician to know what type of questions to ask even, or what type of analysis to do, some of which might not be available in your typical primary care office. And yet we're seeing this over and over as one of the likely manifestations of why people have fatigue and disability and potentially even brain fog. Finally, I'll just say that one of the leads of evidence that might explain a lot of long COVID is microclotting of the blood, for which there is no test in the United States that we can send. So we're in a situation where we have to trust what people tell us. And for decades with chronic fatigue, that hasn't gone so well. Here we are, at least with an ICD-10 code where we can put a diagnosis on paper, thank goodness, and then we can do analyses of how many people this actually affects. But a lot of this is just having to report cognitive function, fatigue, and ability to stand up and work.
Thank you. I'm curious, just as a follow-up on that, when you mentioned sort of some of the internal to the provider community, the chaos that you've referenced, or not believing necessarily in some of these long COVID symptoms, is there a way that a patient or maybe their advocate who is helping them trying to navigate a workplace issue could connect with a different provider who might have more either of an understanding or more direct experience treating some of or trying to diagnose some of these conditions? Or is that just a real crapshoot?
It is a crapshoot, and it's happening in a quite an informal way right now. And it demands that the patients themselves are able to advocate for themselves and actually have insurance where they have a choice, if they do have insurance. The number one piece of advice, rather than having to, it's just too big of a task for me to imagine changing the mind of that physician who says, and unfortunately, the long COVID looks like it affects women more than men. And we know that there's all kinds of bias of physicians saying, well, you're just probably an anxious woman, and this is not a real problem, which is just heartbreaking to hear. The number one piece of advice to that patient is go find another physician, because you're not going to get very far just butting heads and trying to fight with somebody who has those types of ingrained beliefs. So again, we're doing everything we can to spread the word and to make clinicians more attuned to this. From the patient perspective, I think they just need to try to find informally, maybe through advocacy groups or other networks, a clinician who actually just has more experience and sensitivity to this. But that doesn't exist necessarily on a formal basis at this point.
Okay. And as you as you're saying, either directly or indirectly, the difficulty of doing that relies on having access and the ability to search for a new provider, and maybe the energy and the health to take on that fight, which is both ironic and real sad in this conversation. So I want to move on and talk a little bit about the specific remote work accommodations, because as we've touched on, that has been certainly more highly sought, and something that, whether or not you had an accommodation, many people moved to a remote work arrangement at the beginning of the pandemic. I am curious, I guess, Rachel, I'll ask you whether the increased utilization of remote work, do you think it made employers more open to this, more? And I'm sort of laughing because internally I'm thinking, oh, they're skeptical, they're always going to be skeptical. But, I'd love to be a little Pollyanna and think that there are some employers who saw the light and learn, directly saw the benefits of remote work. But I'm curious, maybe from your employment helpline, whether you've seen any difference in employers' view of remote work as an accommodation given its role during the pandemic.
Yeah, again, I kind of consistent with what I was saying before. I'm starting to see some pushback from it, but I think generally speaking, we're moving in the right direction. If nothing else, I think a lot of workplaces are developing more of a hybrid model. And certainly if an employer is going to be providing a hybrid model and allowing some employees to work remotely, then an employee who needs to work remotely because of a disability is much better positioned to ask for that ability as a reasonable accommodation, even if their particular position isn't necessarily a remote one. So I think that I do think that employers have, not everyone, but I think generally speaking, a lot of employers are moving in the right direction. And there's just been a culture change where I think a lot of employees now are somewhat demanding it, right? Again, not every workplace and not every industry, but I think there are a lot of employees out there saying, I've kind of seen how this is working, and I'm not really ready to go back to a position where I have to go back into the office 5 days a week. And so I think that the opportunities are going to be expanded for people. And I think, the key that we advise people when asking for remote work is really to focus on, like, how have you done this effectively, and kind of try to preempt any concerns like that they think their employers are going to have, and then just tackle it. So as Claudia said, like, let them say no. Say, I love my job. I want to work here. I know I can do this job. And here is exactly how I've done it. Here's my list. Here are my 6 positions. Here's how I do each of these 6 tasks remotely and why it's effective. And, really make the best case that they can by being intentional and thoughtful and present that to the employer.
So I'm curious, the cultural shift that you mentioned, which I think we're all sort of seeing, the push for more remote work or more hybrid work. What role do you think that, or sort of and I'm going to put this generally, you don't have to talk about anything political if you don't want to, but there has been a politicization of mitigation measures just in society generally, and I think obviously in the workplace. And I'm wondering if those culture shifts and the political nature of some of those mitigating measures that might be the opposite side of an accommodation coin, what those look like and whether they've had a real impact on an individual's ability to secure the accommodation that they need. If what they need is a clear mask, if what they need is masking, if they need something that has been very front and center during the pandemic because of the politicization or the culture shift around those. And I'll put that out for anybody who wants to jump in. If not, we can move on. I don't want to put anybody on the spot, but it does seem like there are things that people need for legitimate disability reasons that unfortunately have gotten a little bit, people get sidetracked talking about them, is maybe how I'll say that.
Yeah,
Well,
this is, oh, go ahead, we're all, yeah, go for it. Doc.
I'll just say quickly, I mean, it's been very diverse, the response of different employers in terms of what accommodations they're willing to give, but I'd say it actually has been a nice thing to have OSHA as a federal backstop to be able to just basically put their foot down and say that this is the type of mask that healthcare workers need to have access to. Potentially, this is the type of working conditions for healthcare workers themselves in terms of what they are willing to expose them to. So in that way, you know, it hasn't gone as well as I would have hoped with respect to vaccination requirements and masking and that type of thing, but at least that body is a single authority that can sort of dictate to a specific cadre of employees, such as healthcare workers, what is the minimum standard.
Well said. Claudia, did you want to jump in?
Well, just to say that, I mean, I think that it is really hard for most workers to request and achieve masking in the workplace if masking is optional. And I think, you know, the exception might be professional workers, you know, white collar, quote unquote, office workers. We may have more ability to make that kind of request, but I think the average worker is going to have an uphill battle getting masks instituted in a mask optional workplace. I think the response will be, well, you're welcome to wear a mask, and that, you know, that will be the give.
Okay.
And I'll just highlight, I'm kind of avoiding the politicalization question, but just to highlight that, of course, you know, with this interactive process that employees and employers are supposed to engage in, there's kind of an option, right? So like for masking, which is so politicized, like I think a lot of employers who don't want to get into that and then tell their employees to wear masks, then they do have an obligation to just say, not just say no and we're done. Like there is an obligation to do this back and forth and to say, okay, well, if we as the employer aren't willing to have a mask mandate, then we are going to give you, employee, you know, the option to work remotely or the option to have a private office. Or it really can't just be like no and that's it. Like it's always no but, right? And so I think as advocates, we need to encourage our clients when employers say no, you can say, okay, well, I'd like to continue this interactive process. If this isn't going to work, what other ideas do you have? Here are some other ideas that I have, and just try to keep the conversation going and never just accept no as an answer, because it really isn't supposed to be no based on the interactive process.
That's a really good point, that the rules themselves, the process is set up to be more than just a response and one answer. So I'm curious, I'll take this a little bit further, sort of to focus on the role of public health guidance in workplace accommodations in particular. And I'm wondering, you know, both from a legal and a medical perspective, to what extent should workplace accommodations be tied to public health guidance, which over the course of the pandemic changes. And I think the speed or lack of speed through which courts and the legal proceedings, whether it be an administrative complaint or a court decision from which we get guidance about this, happen takes a certain amount of time, which is why we don't have a huge body of case law now that we might a year from now or 2 years from now on this area. So I guess I'm curious, Dr. Ramers, from your perspective, to what extent should a patient modify or direct their workplace needs to whatever the current public health guidance is, either nationally or locally?
Well, first a comment that local public health departments and officers have been victim to all of the politics, and some of them even voted out of their positions because of, boards of supervisors that don't like their political stance. I think the CDC is just, in the crucible here and has done its best to try to come up with reasonable science-based policy that can be referred to in terms of, what transmission of SARS-CoV-2 looks like. And so that at least is something that we can rely upon. But I'll tell you, in my own experience, I mentioned we're right now doing a study on household transmission of COVID. And these variants have become so infectious that I don't think CDC guidance goes far enough to protect household members. So we are actually going beyond what that CDC baseline guidance looks like in terms of isolation and trying to mitigate transmission. So it's the best we have, I think, and thank goodness we do at least have a CDC to come up with normative guidance, but it's not perfect, and in some cases doesn't serve the practical needs of the individual case, is all I can say.
So I guess Claudia and Rachel, if you have a client who is severely immunocompromised and we're dealing with a highly infectious variant, and maybe the CDC or other national level public health guidance hasn't caught up to that, what should that individual do in terms of their own knowledge of what they need to keep themselves safe, and if that maybe modifies whatever their accommodation request is? If you can't sort of point to CDC guidance or other public health guidance, what do you do in that situation?
This is Claudia. I mean, we have gotten a lot of intakes and concern from people with very significant disabilities who are highly immune compromised about the change in the mask mandate for transportation. And so people who maybe they have a safe workplace, but the only way they can get to work is by using public transit, which they no longer feel that they can do. And so then you are back to a situation of, can you get a leave of absence? Can you telecommute? So that's where you're at.
Yeah, and I was gonna say something similar. I think the guidance out there is like the floor and not the ceiling, right? Everyone has their individual needs. And so just because there isn't guidance about something, that certainly doesn't preclude somebody from needing something more affirmative. I think what the struggle is, kind of similar to what we were talking about before, is getting that medical support. Because if you're going to ask for an accommodation for a disability that isn't obvious, employers do have the right to get some medical documentation. And so it's, I think, finding that supporting medical professional who's going to be able to help support your request.
And this is Claudia. I'd like to tag on to that on one item. So at least in the western part of the United States, a lot of us are covered by Kaiser, essentially, managed care. And, certainly a lot of nonprofits and smaller employers use Kaiser. And over the years, at times, Kaiser has been more or less willing to have their providers provide accommodation notes. And so if you're in Kaiser, it's very hard to see anyone outside of Kaiser. So just going forward, if you hear of any trends with a particular managed care company, I'm not saying Kaiser or not Kaiser, but, be sure to reach out to advocates, because maybe there's something we can do to kind of get the managed care companies going in the right directions, because they do at times sort of start trending in the wrong direction. And we advocate with them to go and to support employees with disabilities.
And this is Rachel, just to also tag on, and for all the healthcare professionals out there, I think it's just really important mean, you all are here today, and so obviously you care about these issues, but just remember that, you know, we have had clients who can't get a doctor's note, and, you know, and sometimes doctors will be willing to talk to me or get emails from me, but it's so frustrating when, like, you know that somebody is not going to get this accommodation. And so obviously you're all here, but tell your colleagues to support their patients.
I wanted to sort of talk a little bit about this idea of the workplace accommodation for the person themselves who needs the accommodation. But when Dr. Ramers was talking about the household transmission and the increased infectiousness of these variants, you know, I think it's not unlikely that somebody may wonder if they can get an accommodation because they have a member of their household who is highly at high risk or immunocompromised. Would anybody like to sort of touch on that in terms of whether you can get the accommodation to protect your family members given the changing infectiousness of the disease?
I'll start with the bad news. So when Claudia was when Claudia was going over the definition of disability, she said that folks who are qualified for coverage under the regarded as prong aren't entitled to reasonable accommodations. And there's this kind of other aspect of the ADA where folks who do not they themselves have disabilities, but are associated with somebody with a disability, they have similar protections. And by that, I mean, they're protected from the ADA's traditional non-discrimination, disparate treatment type principles, but they're not able to receive reasonable accommodations on behalf of somebody else's disability. And so under federal anti-discrimination law, caregivers, family members, unfortunately, are not able to have accommodations. But if their employers are providing, you know, are saying, okay, well, anyone can work from home for any reason, then you can look at that from like a disparate treatment type perspective, right? Where you can't treat somebody differently because their need is based on disability, whereas somebody else's need is based on, you know, their kid's sporting event, but you don't affirmatively get accommodations. And then the other point I'll add, and I don't know, Claudia can probably take it better from here, but I've heard that there are, like in Illinois, we don't have this, but in some state laws, I believe there are accommodations for association, and I think California might be one of them, but it's not going to be a federal protection. You'd have to look at your state and local protections.
That's exactly right. This is Claudia.
Okay, so the last question, and I'll just put a plug for the audience. If you have questions that have been brewing, now would be a good time to think about them, type them into the question and answer box. And if you don't, that's okay. Like I mentioned, we will answer any questions that come to us whenever they come to us. But I want to pose this question to each of you, sort of broadly speaking. What's the next big COVID and employment issue? What should we be prepared for?
I can start. I think it's long COVID. I think we are just now getting a better handle and getting our arms around the size of this problem. There's a whole lot, I think, of unawareness. I mean, look, most of my patients are hardworking people making a little bit above minimum wage, if that, and they just have to keep going to work and suffer. And none of them have ever been told that this is even a thing. And I hear over and over again from our primary care providers that can very easily figure out that someone has long COVID. They are so fatigued, they can barely work, they can't think anymore. And this next question is, well, when did this start? And they say, oh, January of 2022. And when did you have COVID? Oh, January of 2022. So there's, I think, going to be a real upswell in the awareness of long COVID. And then we're all going to be trying to figure out what that means in terms of our workforce. And if the numbers are as we think they are, we're talking tens to 20 million people, many of whom are in their 30s and 40s and are really a major part of the workforce. This is going to become a major issue for the whole country going forward. So increasing awareness will result in increased diagnoses, and then the law and the courts and the employers are going to have to figure out how to deal with it.
This isn't directly responsive. This is Rachel. This isn't directly responsive to your question, Katie, but I just want to make sure we don't wrap up today without talking about it. I think a lot of our discussion is focused on some of the more physical related aspects of COVID and long COVID. And I just wanted to make sure that it's really clear that folks who have mental health related disabilities, I mean, all of these same principles apply, right? So, you know, I know that I have had a lot of clients who the pandemic has either caused or exacerbated mental health disabilities, and they need certain accommodations that, again, aren't about keeping them safe, physically safe from COVID, but are to help with their mental health. And those are certainly protected by the ADA and need to be part of the conversation as well.
That's a really good point. And it's, you know, we've probably all heard some of the reports about the mental health impacts that COVID has had on, you know, children and kids who attend school and school closings and not meeting peers without a mask on, all sorts of impacts, but it is not limited to that. And whether it is a new mental health disability or a pre-existing one that is exacerbated, really important point.
And this is Claudia. I am not an economist or, you know, a vocational expert, but anecdotally, it seems as though there is a big shortage of applicants for open jobs, and there is speculation that some of this is due to the impact of COVID and long COVID. And so if that's true, if we have shortages in various places in our economy, then that's not something civil rights will close. I mean, we can address certain aspects of that, but that may be the kind of thing where we need state and federal government to think about additional and those kinds of big interventions.
That's a really great point. And in fact, it gives me a nice segue to answer one of the questions that was submitted in advance, which went to sort of what can we do to help advocate for COVID-related disability protections. And I think that can raise a number of different responses, but one of them is around things like paid leave in the workplace. And that if there is a shortage of workers for the number of available jobs, but that there were paid leave or other protections in place that would allow people to take leave as needed and maintain the job and keep working, that might address some of what Claudia was mentioning. There are, you know, in terms of what you as a person who asked this question or a participant today can do, I mean, there are, I won't comment on specific legislative proposals. There have been some out there. There were temporary paid leave protections in the initial COVID relief legislation package in 2020 that have now since expired. There are advocacy organizations who have been working on paid leave advocacy for many, many years, and for whom this issue during COVID, I think, probably highlighted their work. So there are efforts that could be supported there. I think, you know, to answer this question in terms of how can we advocate for disability, COVID-related disability protections, I think one of the themes of this whole series is what health centers and health professionals can do to advocate and help support their patients. To go to Rachel's recent point and Claudia's point about sometimes the difficulty in managed care health plans, supporting, you know, educating your patients and empowering your patients and then supporting them directly in those needs is one of the most helpful things that you can do, whether it's, you know, if they're at the point where they're working with an attorney and helping that attorney, but also even before it gets to that point, just writing providing as much information. And obviously there are limitations to what we can say or point to about long COVID, but there may be an ability to document or have the patient document and then in some way have the provider document some of the symptoms or some of the functional impairments that come from living with those symptoms. As I mentioned at the outset, I think we're going to, you know, it's very difficult to receive disability insurance benefits from Social Security Administration, and I don't think that's going to change. because of COVID. In fact, I think this is just going to, and I don't mean this to sound negative, but I think it's realistically going to place a huge burden on the system that already was really wobbly. So I don't know what to say about that system. I think we're also going to see an impact from private insurers on long-term disability plans. And in fact, there was an article in the Washington Post a few months ago that highlighted several patient stories of people who have had very significant impacts from long COVID, who have had claims denied. I don't know what to say about other than watch that space, because I think it's going to become a real battleground as people try and navigate and live with this. So that is all we have for today. I don't see any questions in the question box. Are there any other sort of comments from panelists?
This is Claudia. I just want to re-emphasize that if you have a patient in this situation and you need supports to assist them, you can reach out to Katie's organization for support. You can reach out to your local protection and advocacy agency, which is usually called Disability Rights and then the name of your state. And you can also go to askjan.org, which I'll put in the chat, which is a federally funded technical assistance provider around workplace accommodations.
This is Rachel. I'm going to also put in the chat the website for NDRN, the National Disability Rights Network. That's the parent organization of all the PNAs. Equip for Equality is one of the PNAs that are not called Disability Rights Insert Name of State, but we are part of the network. So also happy to connect folks with our sister agencies. We are the one for Illinois.
Thank you for sharing those.
I put a couple links in for our project, which is really focused on clinicians. And so at least expanding the minds of clinicians everywhere and recognizing that they should listen to their patients regarding this group of conditions, which aren't always showing up on the tests that they send. But I think we are, we've learned so much so quickly with respect to COVID that there should be some breakthroughs coming in the next year. When you throw $1 billion at something, which the NIH's Recover program has, we should be able to learn more about these conditions and perhaps develop better tests to identify it, or at least a more solid definition of what this actually is. So hopefully we can move from a very nebulous and difficult to prove thing, which makes employers and the law perhaps quite skeptical, to something that's a little bit more agreed upon.
Well, that is the hope we all need today, to have some advances and some more knowledge. I agree. That's wonderful to hear. If there aren't any other questions today, but if you think of questions after we quote unquote hang up today, you can consider joining me for some open office hours sessions that I'm going to hold related to this series, June 2nd, June 23rd, and June 28th at 2 p.m. Eastern Standard Time. If you have registered for this series and therefore you're on this webinar, you should have received an email with information about how to access those office hours. It will be held through Zoom. And please come and bring any questions, especially if you think about them afterwards, or if you'd like to connect with me and get some connections to other advocates working in the field. I'd be glad to do that. So with that said, my thanks to all of the speakers today for joining me and sharing all of your expertise and knowledge. I've been enriched by it. I hope that the audience has as well. And my thanks to the National Center for Medical Legal Partnerships and Health Outreach Partners for sponsoring this session today. Take care all.